All right, well, welcome everybody. This is the 7th and final Wednesday night with a master therapist, and we're joined by Brenda Wiederhold, who I'm going to tell you a lot more about in a minute. I have so much to tell you about, I had to write things down because I was explaining to her that her credentials exceed my short-term memory. So I need helpful aids here. But before we get to the interview, I wanted to sort of cycle back to the beginning. And when I was envisioning doing this, which is really a new experience for me, I sought some input from a number of people, some suggestions. And one of them was easy because it was a suggestion that I made to myself, which was just to be myself, which for good or bad, I've been trying to do. And the other best suggestion I had is from my friend Charlie here. I don't know if you remember this, but you told me that what the job of the interviewer is to channel the curiosity of the audience. You remember you told me that, or?
I'll claim it.
Okay, all right. Well, I'm attributing it to you, you know. Although when you interviewed me, you talked more than I did. Okay, which, anyway, so it's going to be very easy for me to channel the enthusiasm of the audience because I'm personally we've had some great speakers, don't get me wrong, but I'm particularly interested in what Brenda is doing and her thoughts, because the area that has such great expertise in is at the interface of digital technology and psychology, digital technology and clinical psychology to be specific. And I'm very, very interested in that, and we both worked in that broad area together. So again, I'm very, very interested, in that. Let me tell you about some of Brenda's credentials, because they're really quite amazing here. She is the president of the Virtual Reality Medical Center in San Diego. She's the chief executive officer of the Interactive Media Institute. I'm going to ask you about those two in a minute. Okay. She's also the clinical instructor in the Department of Psychology at the University of California at San Diego, a member of the medical staff at Scripps Memorial Hospital in La Jolla, and in her spare time, the editor-in-chief of one of the preeminent journals in the area of cyberpsychology called CyberPsychology Behavior and Social Networking, which we've given you a little bit of a description, on your seat there. So pretty amazing. And my first question for you, I think, goes very neatly from all the credentials, which is, do you ever sleep?
No.
No. All right, there you go. All right. Well, could you? I mean, most of these are somewhat self-explanatory, but what's the difference between the Virtual Reality Medical Center and the Interactive Media Institute?
Sure. So the Virtual Reality Medical Center is an S-Corp. It's a privately held S-Corp, and we have clinics in the San Diego area, in Belgium, and in China. The Interactive Media Institute is a 501c3 nonprofit, and I publish the journal under that. It's published by Marianne Liebert in New York, but I'm the editor-in-chief. We do research projects. We hold an annual conference. We're doing our 24th annual conference this year in Norfolk, and the 25th annual conference will be next year in Milan, if you're interested.
I'm going to that one.
Yes, please. And so we try to educate the public. We do publications for the general public and the scientific community under the nonprofit as well.
Right. So I guess one of the credentials that I failed to mention is that you're also an MBA, right?
Yes.
You're a PhD MBA. It's unbelievable. Okay. So how did you get into this broad area of the juncture of technology and clinical psychology? Because you've been at this for a while. You're saying you did this for 24 years, this this conference. So you've been really a pioneer in this field. And how did you get interested in it? Because you kind of formed this area.
Sure. Two different ways, really. One was, since I was 15, I was interested in dream research and sleep research, so an alternate state of reality. And the second is, I took a circuitous route, got my master's in business, came back to psychology and said, I can't any longer just say, how do you feel today? I have to put a sensor on you and see what your heart rate is, your respiration is. And so when I found out about virtual reality, it was the perfect kind of Skinnerian box. If you put somebody into a virtual world, you know what you're showing them. You can measure their physiology and see their reaction. So it's a perfect little box to know what's happening with your client and individualized therapy. It's also an altered state of reality.
So when you have a client who's in a virtual environment, you combine that with various kinds of biometric assessments?
Yes, anybody that comes in the office gets a biometric assessment, whether it's an elite special forces, an athlete, a child with autism or ADHD. I monitor that and I empower the patient by showing them their physiology as well and letting them to know you're relaxed now or you're anxious now.
And what was the state of virtual reality when you first started doing this? I mean, I don't really, I'm trying to think back, 20 years ago. Did they even have virtual reality?
They did. I went to a conference called Medicine Meets Virtual Reality that was held in San Diego, and I went to a talk by Luigi Pugnetti from Italy. He was a psychiatrist. He's now passed on. But he was talking about, what if we put a person into this environment, measured their physiology, we could tell what's going on, and I said, oh my God, I was looking for a dissertation topic, and I said, this is brilliant. And so I managed to get one of the first 4 VR systems that was on a PC. Before that, they had been on $1 million workstations.
Wow.
So I felt very fortunate for that.
So that was just the beginning.
That was just the beginning.
Yeah.
There were very few worlds available.
Right. So who would you say is the originator of this? I mean, we know who, like Jared Lanier. Jared Lanier was the one who coined the term virtual reality. But who was the first one to try and use this as a mental health platform?
There were actually 3 groups. Ralph Lamson, that was in Northern California, did Fear of Heights as a pilot study, and then Max North in Georgia, and Barbara Rothbaum and Larry Hodges also in Georgia. So they all did pilot studies. And so for my dissertation, I did the first randomized controlled clinical trial using VR in psychology.
Wow. And the people in Georgia were also working with Fear of Heights?
They were working for...
That was the original target.
Yeah.
Now, in Los Angeles, a kind of seminal contribution was made by Skip Rizzo. I don't know if you ever met him.
Oh, yes. He's
Yeah.
one of our closest colleagues.
Yeah, I mean, he's amazing.
He's very amazing. And he doesn't sleep either.
Oh, he doesn't? So this is the common denominator.
Yeah.
Now I understand. I sleep too much. So Skip Rizzo, I don't know if you have heard that name before, and correct me if I get anything wrong, but he developed a virtual environment. I believe it's called Virtual Baghdad, right?
I think ours is called Virtual Iraq and his is called Virtual Baghdad or something like
Yeah,
that.
I think it's Virtual Baghdad. And so what he did was he created a virtual environment for soldiers coming back from the Iraqi war who were traumatized by some of the experiences that they had. And some of these soldiers really were in areas where they didn't have quality services for trauma along the lines of what we heard a couple of weeks ago. And he was looking for a way to deliver services, and so he thought that the virtual environment would be helpful. So he would create this virtual environment, very realistic. The soldiers who were either too far away or didn't want to come in and admit that they needed help would come into the environment in avatar form, and he would deliver services mediated through this virtual environment. They might have renditions or simulations of a improvised explosive device going on, and then he would try to deal with the anxiety and the reaction that they might have. Is that about capture it, or is there anything you would add to that, or?
No, I think that's about what it.
And in your simulation in virtual Iraq, was it similar?
Yeah, so we were funded, Skip's group was funded, and Hunter Hoffman, who's at University of Washington in Seattle, we were all funded at the same time by the Office of Naval Research to develop worlds and test them on different populations of the military coming back.
Right.
And he was at ICT at USC.
Yeah, which is right down
right down the
hill.
road. And so we were all funded to do different parts of the development. And so they're different in certain aspects. They use different techniques, but they all put the person back into Iraq or Afghanistan in a safe way. Ours also uses the physiology.
So Rizzo didn't use the physiological measures.
No, not in the beginning. I think he might be using that now, though.
Right.
Yeah.
Because you're saying you get a more fine-grained sense as to whether or not the exposure is causing too much anxiety or is too disorganizing. What does that add other than just asking for the individual's report? Would the soldiers try to act like they were not as affected, and this enabled you to get underneath that a little bit?
Sure. So it's very important whether a person has a phobia or a trauma, but especially in the case of the phobias or the traumas, we don't want to re-traumatize the person.
Right.
And so a lot of these, especially you think of a Marine, they're used to just, sir, yes, sir, I'm doing fine. And if you see their heart rate going too high, you need to say, okay, let's stop and do some breathing, or let's just sit in the world. Do you want to take the head mount off? Giving them that permission and seeing what's happening with them so you can go slow enough.
And is the biometric data an accurate indicator of their subjective experience? In other words, are there times that you might see some kind of physiological arousal, but subjectively they're okay?
So I actually did this in the beginning with my phobic patients, and I've seen that it holds for chronic pain and for post-traumatic stress disorder. There's almost 4 kind of gross type of patients we see. So type 1s say they're anxious and their physiology shows they're anxious. Mm-hmm. Type 2s tell us they're not anxious and their physiology shows high arousal. And if you talk to the person and show them that, they start to sometimes admit that, yes, I am indeed anxious, but I was embarrassed to say so, the stigma.
Okay.
Type 3s are people that say they're very anxious, but their physiology shows nothing. They're probably not immersed or present, and you need to do something to get their physiology aroused so they can desensitize them. And then type 4s are not getting aroused and are being quite honest about that.
So are there some people, is there a 5th category where they actually feel, where there's actual arousal and they don't experience it, not because they're not reporting it, but because they actually don't, they're dissociated in a sense, although their body is still experiencing the heightened arousal.
So thank you very much. You have cracked the code.
What I did?
Yeah, you cracked the code. It didn't take you
It's
long.
because I slept last night.
Actually, we measured brain waves, and a lot of those people, then you break it into more subsets. So there are people that's peripheral physiology shows nothing, but their brain shows that they have it. So
Okay.
they are dissociating.
Okay, so walk us through this situation. So you have a soldier that comes in, you hook them up to these electrodes, right?
Correct.
Then you bring them in avatar form into the virtual environment?
We don't bring them in avatar form.
It's just a first person
It's a
kind of
first
view?
person, correct.
So they would be looking at a screen. Do they have
The head mount on.
a head mount?
Yep.
Okay, so it's not looking at a screen, they're looking at it through,
No, they're looking at it through a head-mounted display so they can move their head and see 360 degrees around them.
and they're sitting, or do you have them ever stand up? So there's a sort of kinesthetic movement aspect to it.
Sure, so it depends. If they're in a convoy, they would be sitting. And if they're in an environment where they're patrolling the city or going in the hospital setting, they would be standing.
Okay, okay. All right, can everybody visualize that? Okay, so they have this head-mounted display, they're in the environment, seated or standing, based upon it. And if they're standing, they could be moving, they could be walking, or?
No, not right now. None of us have that. There is a 360 platform that you can move on. They're very, very expensive, and nobody has those yet for working with the mental health disorders.
I see, okay. Because I think they have them outside of mental health environments, don't they?
They do, mostly for rehabilitation.
I see, okay. All right, so they're going through this procedure, and then do you introduce, based upon the physiological data, an aversive or anxiety-producing stimulus? Is that something that you would control as a clinician, or is it built into the software when that happens?
No, so basically there are certain stimuli that are built into the software, but then as they stabilize physiologically, then we add more stimuli.
Okay.
So we can add call to prayer or RPG rounds going off, different things for the military, or for a person with a fear of flying, you could add turbulence if they started to stabilize.
Right. So how much flexibility do you have? I mean, do you spend, like in a traditional clinical situation, we do an intake interview, maybe even a couple of interviews, getting background and what their experiences were. Do you do that, and then are you able to modify to some degree what their experiences will be based upon the sort of report about the trauma they experienced?
Sure. So we do a clinical history and intake eval. We teach them skill sets, so breathing, cognitive techniques, and then we put them into the virtual world based on their experiences. So we can start them at different levels, and we can go, it's not all just in a uniform manner, it's individualized for the patient. And just to say too, it's only one part of the treatment. So when they come into the office, we still do, what would you do for your homework, what happened since the last session, go over that, do a baseline. Then we go through the whole virtual reality, then we do the debrief and assign new homework.
So this might be adjunctive to a traditional PTSD intervention. We talked about in here, CBT, prolonged exposure, various kinds of evidence-based treatments of PTSD and trauma. So what you're describing is that the VR component of it would be adjunctive to that basic kind of treatment.
Correct. So what I say is we do virtual reality and biofeedback enhanced cognitive behavioral therapy. So it's just part of the exposure part of cognitive behavioral therapy.
And what do you do can you deliver these services in a fully remote form? In other words, let's say that you had a soldier that was living, hundreds of miles from you, and there was nobody who was able to do this intervention. So you wouldn't have the biometric data unless, could they possibly have a biometric data that could feed in somehow to your program, or is that not possible?
At the moment, nobody has that. Everybody's working on that, and we all know that we need to move towards that.
Yeah.
But nobody's been able to do that yet.
Because there are people who can get their pacemakers assessed through a phone line or something like that. It would seem like that should be possible to do that.
Yeah, there hasn't been the ability to monitor their physiology with the things that work in the clinic yet remotely, unless somebody's there to put the sensors on. But now with smartwatches, with a lot of the other monitoring, that's what we're moving towards. Right now, we send the patient home with iPads, iPhones, Google Cardboards, so that a portion of their treatment can be done at home, but it doesn't include the physiology except for a smartwatch.
Right, right. And if you don't have the physiology, do you rely upon their subjective report in terms of modulating the intensity, of the anxiety?
Correct. So right now, we have to just say, this is what you're taking home, and we don't give them anything that they haven't already mastered in the clinic. We give it to them to practice if they've already mastered it in the clinic. But we don't want to go too quickly.
How do you deal with the age-old problem with VR of nausea? Because in a clinical session, a typical clinical session would last 50 minutes. Now, it doesn't sound like you use the entire time. So what's a typical duration that they're in the VR setting?
We use 20 minutes most of the time, maximum 30 minutes.
Okay.
We don't do it longer than that. We have some people that have a bit of vertigo or like motion sickness.
Right.
And we can pre-treat them with the anti-motion sickness drug without them having any side effects as far as not being able to get immersed or present in the virtual reality, not having the therapy go forward. So it actually works quite well. And virtual reality can almost be something that is used to diagnose vertigo, because I often have people that get very nauseous after 90 seconds.
Right.
I can send them to a neurologist, have a workup, and oftentimes they have an undiagnosed vestibular problem.
So if they didn't have a vestibular problem, do you think most people can tolerate the virtual exposure for 20, 30 minutes?
Most people can. We had, with the older headsets, we had a 2% rate of cyber sickness, and now with the new head mounts, because they're so realistic, we have a 10% rate.
Wow.
So it has gone up, so that's a bad side effect of the new technology.
And the anti-vertigo, is that an over-the-counter medication?
Yeah, so they can use like Dramamine or something like that.
Right.
Or they can, if they have something more serious. I have some people that had a vestibular
Or
disorder.
these bracelets sometimes that people wear, like if they go on a cruise or something like that?
Correct.
Do they do that sometimes?
Yeah, I've had people do that, and I've had one gentleman actually had a drug from his primary care physician because he had such bad vertigo just in the real world. And he was able to use that and come to the VR and do just fine.
So you don't have a psychiatrist on site to work with you?
I have somebody in our office suite.
Oh, okay.
He's not employed by us, but he's a consultant because we usually see the patients now at our Scripps Memorial Hospital office, and so we have a suite with several different disciplines in it.
Okay. So, and you said something about that the typical course of VRET, virtual reality exposure therapy, is 8 to 12 sessions?
That's for phobias.
Oh, for phobias?
Yeah.
What about for trauma?
For trauma, it's usually 15 to 20 sessions.
Okay, and you take data on, what kind of outcome data do you take on that?
So we did a randomized controlled clinical trial funded by the Office of Naval Research. We had an 80% success rate and no dropouts. And in that, we kept the logs of did they go back and get a job, go into an educational program, go back into active duty if they chose to. So that was the outcome, is were they able to be gainfully employed or go back to school if they chose.
Yeah.
And we had an 80% success rate from that. Also the checklist that you have to do, the post-traumatic checklist.
So do the insurance companies consider it an evidence-based practice?
They do.
They do.
It's quite amazing. I had a very nice insurance lady back in the 90s when we started, and I called her and I said, I'm using VR. How do I code this for insurance? And she said, what are you doing? And so I told her what I was doing, and she said, that's just exposure therapy. You're not taking them in the real world. You're not taking them into their imagination. It's exposure therapy.
That's
Code
right.
Code it the same way you would. She said, we don't care what tool you're using. You're doing the same therapy. And so that's the way we code it.
And that's been reimbursable?
We are a cash business. We're a private pay clinic, but we do give the patients a super bill, and most PPOs will reimburse. A lot of HMOs are starting to reimburse. And last month I had my first Kaiser patient that reimbursed. 2 patients from Medicare. So a lot of people do get reimbursement now. And
Yeah.
we have our system in about 13 VA hospitals, also in Poland, helping the coalition troops. And that's a different medical system, obviously, but they accept it as evidence-based.
Right. And you mentioned earlier that you have clinics here, Belgium, and also in China.
Yes.
I wasn't aware of the China location. When did that happen?
I think we opened that in 2010.
Mhm.
I have not been as involved in that. My business partner has been. But we opened that in Qingdao, China.
Mm-hmm. Okay. So where do you see this heading? Do you see this as something that could become, as a technology is more accessible and less expensive, do you see VR as being a kind of common clinical tool rather than something that is really new and trailblazing?
I see it becoming more common as it becomes less expensive and easier to use. I think the ease of use is very important to the clinician. They want to focus just with them and the patient. They don't want it to take away from the therapeutic rapport.
Mm-hmm.
I think we need to start training students in their programs to use these technologies in a seamless way so that when they get out and are on their own, it's nothing to them. They think it's part of clinical practice.
How much would a training program need to spend in order to get a state-of-the-art VR set up?
It depends. I mean, right now the problem is not everything is on the same platform. So you have to choose what you want to train in. Do you want to train in phobias? Do you want to train in substance abuse? Do you want to train in chronic pain? And everything might be on a different platform and have to be
Wow.
bought from a different vendor. That's the only problem.
Right. But what about the hardware?
No, the hardware you can just choose. Do you want HTC? Do you want Oculus? I mean, I
Right.
think the Oculus that came out yesterday is something like $500 and the bundle is less than $1,000.
Okay.
So it's
It's a
pretty
software
amazing.
issue, really.
It's a software issue. The hardware has come down dramatically and it's not so quirky as it used to be.
Yeah. Let's extend it, because I think by talking about the exposure therapy for veterans, it gave the people a kind of a good visual sense of it. But let's show the flexibility of it, because it's not only being used with anxiety disorders.
Correct.
You and your group have done a lot of interesting work in using VR in terms of eating and weight disorders. Could you tell us a little bit about that?
Sure. So virtual reality has been used a lot with anorexia, with bulimia, with binge eating disorder, with obesity. And you can use the virtual reality to put the person in an alternate world, again, measure their physiology if you choose, and see what's cueing that disordered eating. So if they're in a grocery store, if they're in a restaurant, what's causing the anxiety related to the eating?
Okay. What about the more sort of body dysmorphia aspect of it? Let's say that someone who is, has anorexia, then they're going to feel very, very uncomfortable with what society would consider to be a normal body weight, a BMI or something. So how have you used virtual platforms in order to address the body dysmorphia issue?
Sure. I have not used that specific. I have the software, but that's being used mainly by Giuseppe Riva, who's one of the pioneers in that system in Milan. And he puts the person
in Milan, where you're having the conference.
Where we're having the conference.
Next year, I remember
yes,
that.
and Giuseppe's my co-chair and co-organizer.
Okay,
so,
good to know.
Yeah. Milano.
Okay.
So you put the person into the world, you have them look at an avatar and change different body parts of the avatar. So how big do you think your chest is? How big do you think your waist is? Then they scan the person's actual body measurements into the virtual world. They superimpose those onto the avatar, so the person has to see just for a moment that they have a distorted body image.
Okay, so they put in a digital representation of their actual physical proportions, and then they compare that to the person's conception of what they look like in physical reality.
Correct.
Okay, and then the statistical measure would be the discrepancy between the presumed and the actual body mass.
Correct.
Okay, and with therapy, are they trying to bring those two things together?
Together, yeah. And that's what they've done. Giuseppe's done this with over 500 patients in Italy, and he has a very high success rate and a 1-year follow-up on that success.
Has he ever done, we were talking before, and has he ever done the approach that I was suggesting or talking to you about, which is where the individual would actually customize their avatar to be not how they see themselves, but how they feel comfortable looking, okay? So that the customization would probably be creating an avatar that we would think was extremely thin, okay? And that's what they would be comfortable with, okay? And then have them take that as a baseline, and then each time the exposure would be in a tolerable level, expanding the body mass index of the avatar that they operate, and see if they can tolerate that until the avatar became more normative in their proportions, and see if the individual can tolerate that physically.
He does that as
He
part
does
of the
do that.
experiential piece. Yeah, so
Okay.
he has their body, what they think their body is, what their body actually is, and what their ideal body is.
Okay.
And so trying to bring those together.
Right, okay. So we have eating disorders, we have a wide variety of anxiety disorders. In a way, the method of approaching eating disorders is a kind of exposure therapy.
It is,
Yeah.
yes.
I mean, so it's linked there. What about, you've done a lot of work on pain management is another area that has proved useful with VR. Could you talk about that a little bit?
Yeah, so we use the virtual reality. In the beginning, we used it during procedural pain, so dental pain, pain during surgery, pain during medical procedures. And then now we've moved, about 8 years ago, we moved to chronic pain as well. And we find we can use the virtual reality as part of a cognitive behavioral therapy protocol for chronic pain, getting the person even to exercise in VR, because a lot of people in chronic pain start to get afraid of movement, for instance. And you can put them in the virtual reality, have them start jogging, have them start swimming, have them start doing different physical exercises, get a positive emotion, a positive feeling about that, and then carry that over with some exercises at home now in the virtual reality.
Yeah, I mean, and the interesting thing is that you're getting them to exercise in a virtual platform, but then do you find that it generalizes to their behavior in the physical realm, which I guess is your ultimate outcome.
We do, and it's amazing. People have done fMRI studies looking at the brain, and when you're walking, no matter if it's in the virtual world or in the real world. Your brain lights up.
That's
Yeah.
what I think a lot of people have trouble with, because they often describe the virtual world in contrast to the physical world. They refer to the physical world as the real world. But in fact, both the real physical world and the virtual world are experienced by the brain as some kind of simulation, some kind of construction.
Well, and think of it, your world right now is not the same as my world. So it's all about perception.
Yes, exactly. So if we think of it in that way, that it's an alteration of our, the way we represent the world, that the possibility of generalizing from the virtual world to the physical world really makes more sense.
It does, and it's amazing. I've had patients that said the real world is more real after being in the virtual world.
It's very interesting, yeah.
Yeah. So being in the virtual world changes your perception of the real world in a way you didn't. So it moves back and forth. It's very fluid.
Yeah, yeah. I mean, we could talk about that a lot, but I just want to stay on this in our time. That's the VR piece. Now, we all know that AR, augmented reality, is developing rapidly. Some of the work being done at Magic Leap, for example, is just extraordinary. How do you see the future of augmented reality and mental health?
So one of the places that I see it really growing and being more necessary than VR is in rehabilitation. So if you've had a stroke and need to learn how to move again, wearing a head mount may not be practical or the best way to rehab, but if you use augmented reality, you can be in front of a computer screen, you can be an avatar, and you can interact with that virtual world but without a head mount on. I also see it for education, training surgeons, training children. Using the augmented reality may be better supported for that.
Maybe we need to back up a little bit and just give a short definition of what you consider augmented reality. I think there's a lot of different definitions.
There's a lot of different definitions
How
out
are
there.
you thinking about it?
I'm talking about not wearing a head mount, but having a three-dimensional screen that you interact with in some way. For instance, in the rehabilitation, if you see an avatar moving an arm and you're moving your arm at the same time, that's augmented reality. So you're touching a ball, but you're not really touching the ball, but you see yourself touching the ball. That's augmented reality.
Yeah, see, I mean, I have that idea, and I also have the sense that there'll be digital information that is just overlaid on your physical reality, so that, let's say you were doing exposure, that you, instead of having the individual inside a virtual environment, you can have them in the physical world, but overlay digital information that they're afraid of or anxious in the presence of on their physical experience. So it's almost closer to the physical experience.
So Pokemon,
I think, is going to go down in history as a major event.
It's a major event. It's being used in mental health treatment. It's getting people to get out of their houses and go look for the...
That's interesting.
Yeah. So, and so that is a very good example. I'm thinking more of the clinic-based, but on the smartphone, which is really where it can make an impact. People can take things home and do them at home with that sort of AR. And you can't do that as easily in VR.
That's what I was thinking, that, it's much more scalable and flexible.
It is.
Yeah. So AR, we've just dipped our toes into that. I think the VR has been much more developed, and I'm really excited to see what AR happens. Any other trends? We're reaching the point where I want to just open it up to people. I'm sure they have a lot of questions. There's a bunch of millennial geeks here, and I'm sure they have a lot of questions about this. But any other trends that you're thinking about that you think would be important for us to be aware of?
I mean, I think, well, two things I want to mention specifically, and not to get off on new things, but we're using the virtual reality a lot now with autistic children and people on the spectrum. And so I think, again, taking people that we have thought of as disabled in the past, but that just have different abilities and learn differently, and putting them into the virtual reality, I think, is a very powerful use of the tool. So teaching them social communication skills. I think the other big thing that's happening is artificial intelligence. So combining artificial intelligence and virtual reality or augmented reality is going to bring that to a very powerful place also for the self-help platforms that can occur.
So just give me an example of how AI could augment, or let's say not augment because we're overlapping words, enhance VR interventions.
So if you have artificial intelligence combined with virtual reality, you could actually have the patient's responses drive the virtual world. So whether that's physiological or a chat bot, whatever it might be, but that based on your individual responses, that could drive how the virtual world progresses.
Right.
And for a self-help platform, that could be huge.
That's amazing. Yeah, yeah. Okay, well, thank you very much for giving us a little bit of a tour of some of the cutting-edge things that are being done at the interface of technology and clinical psychology. And I want to just open it up to the audience. Actually, wait 1 second. You mentioned the autism thing. I think we should bring Ian in, don't you?
I think so.
Okay, Ian, can you come over here for a second? I want to
That's
introduce.
his cue.
Yeah, right. I want to introduce Ian Miller here. Come over here, Ian, so they can see you on camera. Okay? In case you say something stupid, we could have it forever. Anyway, Ian was actually a student in my capstone class on psychology and new technology. And I think you did your capstone project on the use of VR in sports, right?
Yeah, for training.
For training, as a training tool, which is very popular right now.
Yeah.
And anyway, he did such a great job that, and I know that you're from San Diego, that I sort of put you two in contact, and you've worked together for a number of years.
3 years.
For 3 years now.
Yeah.
So why don't you tell us about the grant that you got and what you're doing?
Okay. So I went back just last November. I went back to Boston.
Can you hear him? Maybe put it a little closer.
So I went back to Boston and basically pitched our idea for virtual reality and autism to an organization that funds research programs, and we ended up taking home the grand prize.
Which was $90,000, don't be humble.
$90,000, so that was a big catalyst for our program. So
What do you do? What do you do in the intervention?
basically, right now we're testing an air travel module. So we're bringing kids with autism who have trouble navigating kind of complex or social environments. We're taking them and we're bringing them into our virtual airport, and we're letting them go through the check-in process, go through security, go to your gate and wait at your gate, go board the airplane, wait for the airplane to take off, all of the steps throughout air travel. We're taking them through it in a way that they can understand it a little bit better by highlighting the most important context, like, okay, this is the ticket counter lady. This is what we say when, oh, hi, I'm going on a trip. Can I have my ticket? They ask you, do you have any bags to check or anything like that? The security guards at the security check-in will ask, can you please put your bag on the belt? You can get it later. So what we're really doing is highlighting the most important context or points throughout these social contexts to help them learn that, when I go into the real world, this is what I should be looking for.
So 2 questions, one observation and then a quick question. The observation is that you leverage the software that currently exists for the fear of flying. So that was a very smart and economical idea right there. But and then within that environment, you chose just general social interactions. But do you think it's context specific, the learning? That would be my concern.
Right. And, we are developing other contexts to train them in. I think one of our main goals is to be facilitating really what we call functional communication, which is basic communication. Saying hello to people, asking for help, really just basic forms to help people navigate these complex environments. So it would be an interesting study to see if, the skills that they're learning in the air travel module, are they maybe applying these communication strategies in other contexts that we haven't trained them in. That would be a good way to go.
Yeah, okay. Well, I'm glad you came.
Yeah, thanks for having us.
All right. So questions? Yes?
Talking about the VR combined with AI, I'm sure I'm not the only one who kind of sees that as a little scary, like Black Mirror. Like, do you see any, potential, dangerous negative consequences from that? To the point where, you can't tell the difference between reality and virtual reality?
Just for the people who are watching on YouTube, if you can summarize the questions when they're posed to you that way, because I don't think the audio can be picked up from back there.
Oh, okay. So she asked about,
The apocalypse.
yeah, well, to start with, to answer part of your question, she asked about something that's similar to Black Mirror. I watched 2 episodes of Black Mirror and I refuse to watch it now. But she asked about the AI and VR being combined and if that's scary or dangerous or what negative things that might have. I think I will quote Carl Jung again, who I often quote, who said technology is neutral. It's how we use it. And so it's kind of, it's there. The technology exists for AI, for VR, for AR, and we have to try to use that in a responsible way. There are a lot of groups, especially in the European Union, in the National Health Service in Europe, that are looking in the UK, that are looking at how do we control this without the government being overly involved. How do we set guidelines and principles so this is not misused? But I think that could be a problem. I don't think it is at the moment, but it could be used negatively. So that's something we need to be aware of and cognizant about.
Charlie?
Yeah, I have a question following on from that and the Jung quote. I was thinking more of the video games, especially first-person shooter video games, particularly with clients dealing with PTSD. Do you come across those situations where I guess some people may unconsciously try to self-medicate in those sort of games, and are they in any way cathartically positive, or do they pretty much repeat the trauma?
Sure. So all the research is mixed on that. I mean, years and years of research. Some people say that the violent video games are cathartic. Other people say that it causes you to do more violent or negative things. Every research study shows something different, so I'm not sure. I think it may come down to personality part of it, because I know some people that come in and they go kickbox, and that helps them. Other people, that makes them feel more empowered to hurt other people. So I think it's just another form that is affecting some people differently than others. The same with attention deficit disorder children. Some people can use their smartphones and be fine with that. Other people, it causes them to get worse and be more distracted.
Other questions? Yeah, Hillary?
So, from what I'm hearing, VR and AR are very expensive and new right now. Do you see it being accessible to people who can't afford it as much? And if so, how long do you think that will take?
Okay, so the question was about the expense of VR and AR right now and how we think that can get down to an affordable cost for people that can't afford it. What we're doing right now is we're developing apps, and many people are doing this, that are used on a Google Cardboard. So the app may be given away for free at the doctor's office. For instance, right now you go in and you get exercises, but you would get an app that you could put on your phone. Now you would have to have a phone in that case, but you can use it in a Google Cardboard, which is very inexpensive. Right now we give those to our patients when they come in, so we give them a Google Cardboard at their first appointment. The apps are, the problem right now is the software, and it's the cost of the apps. It's not the cost of the hardware right now, but I think it will come down. A lot of things are being put on app stores for free, or at least demo versions. And so I think we're a few years away from that being affordable for everyone, but it's starting to come down to a more affordable cost. We used to sell our systems for $100,000, if you can believe it, and that nobody would buy $100,000 VR equipment anymore.
Any other questions? Jackie?
Can you talk a little bit more about the interface of augmented reality with artificial intelligence in a self-help manner, what that would look like?
Sure. So this has been done a little bit already in the UK by Daniel Freeman at Oxford, and he developed a fear of heights system again. A lot of people develop fear of heights, but I think it's a very common phobia. And he had a person being able to go into that world, and it was automated based on your responses. You would go to a higher level in heights, you would go to a different, harder scenario. So it was based strictly on the individual using that environment. And so you can see that that could be used for pain. You know, if a person's physiology goes up, if their pain scale goes up, their SUDS, you could see it moving differently or stopping. And that's what we do right now. I have to be the human in the loop right now. So for a PTSD patient, if their heart rate's increasing too quickly, or if a person has a panic attack, I have to stop the world or stop them. But the computer could do that. And so we could disseminate it more widely, and the clinicians that use it wouldn't need to be as proficient with this.
Or as existing.
Or as existing, yeah. There's a shortage of
Yeah.
mental health providers in
Yeah.
most places. Yeah.
Yeah, well, I mean, on one hand, that can produce anxiety about whether or not, as AI advances, there will be less need for, as you say, humans in the loop, and maybe there'll be some supervision that the human intelligence might need. But a lot of these things could be, there could be an AI therapist that does a lot of the work, right?
That's correct.
It's not necessarily self-help, but it's not human help either.
It could be kind of a artificial human. Yes, exactly. But I think it partly will still come down to personality, because if you think about, certain people will only go exercise if they have a personal trainer, but other people want to exercise at home alone. Other people want to exercise in a group. So I think there will be all sorts of different technologies that you could use, but you may choose to still go through to a
Yeah,
therapist.
one of our first master therapists was Andy Christensen, who's developed an app that I might have, it's more of a website, but that I think I might have mentioned to you at one point, called Our Relationships. And he has an evidence-based protocol for couples therapy. And right now, most of it is done through self-help, but he found that he got a significant boost in efficacy when he had coaches that would check in. Now, they wouldn't necessarily be therapists. They'd be low cost and there'd be fairly low level of intervention. But with the addition of a small human element, he got a bigger impact. So we're going to experiment with self-help and then chatbots and more sophisticated AI and human beings, and how the division of labor gets worked out will be very interesting. Yeah, Michaela?
What does the VR exposure look like for treating substance abuse?
Okay, so what does the VR exposure look like, or the VR protocol for substance abuse? So it's also exposure-based. So you put a person, for instance, if you have an alcohol problem, you would put the person into a virtual bar, into a virtual restaurant, into those scenarios that they've identified during the clinical intake as causing them problems. You would have them interact in social situations and be able to do avoidance. So look at what their physiology is doing, look at what's triggering that physiological arousal, whether it's the restaurant, whether it's just finishing dinner and eating another drink, and then you would teach them to do the exposure with response prevention.
Okay. Any other questions? One more, Victoria?
So I'm very interested in merging together close relationships and technology. For example, in Japan, they've developed dating simulators that have like a VR component to them. And one of which I was reading, they actually analyze your brainwaves, whatever that means, and then match you up with a virtual girl. And you basically go on a date with that girl. And so first I wanted to know like what thoughts you have about that. And then secondly, if when using virtual reality as for people who are socially anxious or have perhaps like an anxious attachment, if using VR might have adverse effects in which like the patient is more dependent on the VR than they are willing to go out and meet people and develop
So it'd be in the service of avoiding,
Right.
the outcome would be just to feel better in the virtual environment and avoid the changes in the physical environment. So, I don't, you can summarize the question, but I think that's an element of it.
Sure. So two parts to the question, one on the VR dating and then one on the VR and social. So looking at, do they just stay with those skills in the virtual world? We haven't seen that. I started treating social phobia in the virtual reality back in the 90s. And at the time, all we had was something called digital space, and it's where you had an avatar head, but it emoted. It could be angry, happy, sad, smiling, frowning. And I would put the person into that world, teach them about social skills, social space, conversations, and then have them go in between sessions as their homework. They had to go do something, ask for what time it was, ask for directions at the mall, and they were able to translate that. Now that's a person, that's not a couple's or, being in a social situation with another person, but they started to be able to go out to dinner with people, to go on dates. The VR part where you're looking at brain waves and matching people up, did they go on a virtual date or a real date?
Virtual.
A virtual date, okay. So that'll be very interesting. I don't know how that will evolve. I think it could be a nice starting point for people that are severely social phobic, that have not been able to date in the past, as long as there's some way with a therapist, with a bot, with something that they have to translate those skills over, because you can't just learn something in the virtual world. If it doesn't translate to the real world, then it's not of much use, is it? So we want to always see that we have a translational piece, and right now that's up to the therapist to do that.
Although I have heard some people who spend a lot of time in virtual worlds would say, I'm adapting within this virtual world, I'm interacting, I'm having a good time, and why does the physical world have to be the ultimate criteria of success?
Well,
That's very philosophical, I know, but I've heard that.
no, and right now I think it still is the criteria for success, but I don't know if you remember, there was an Outer Limits or a Twilight Zone. I think it was Outer Limits.
So you don't watch Black Mirror, but you do watch
Yeah.
Twilight Zone, or you're not sleeping.
Yeah, well, yeah. Those late night movies. It was called Music of the Spheres. Do you remember this episode?
No.
So everybody under 20 started to hear this wonderful, beautiful music, and everybody over 20 heard noise. Did you see that? No. Oh. And it was amazing because did you see this, Charlie? No.
Charlie was in it, actually.
Write it down. I'm sure it's on YouTube for free. So it's either Outer Limits or Twilight Zone, but it's called Music of the Spheres. And so everybody under 20 had a different reaction, and they were changing. And what it was there was no sun, the layer from the sun. So all the ionosphere was gone. And so everybody over 20 had to stay inside when it was sunny, and everybody under 20 was able to go outside, but they lost their hair, they were silver. So it was just an evolution. So all I'm saying is maybe someday, that's a long convoluted answer, but maybe someday we are going to evolve. I mean, you think about it, we could be, so that everything is done in a virtual world or on the internet. You never know how humans will evolve.
Right, right. All right, well, I wanna, on that note, I want to thank you for coming. It was really a pleasure.
Thank you.
And
Thank you.
okay.
Thank you very much.